Hi, I'm Lindsey, Lindsey Ebbs from Lindsey Ebbs Podiatry, and I'm located in Whitby in North Yorkshire. I have a, Marco the robotic laser, and that's an M6 class 4 laser. I've had lasers now for about 25 years, 26 years probably, and I've had a class 3B, and now obviously I've had a class 4. So lasers have been part of my practice for a very long time, and certainly I appreciate the effects that laser brings with it. And since I've had the class 4, it's only improving my patient outcomes in clinic. So yeah, I'm converted. The results that we get with Marco, forgive me because I call him Marco because he is our assistant in clinic, so I sometimes forget that he is actually an M6. And actually patients book in to see Marco, so we very rarely refer to him as the robotic razor anymore. So the reasons why I like Marco and the results that we get in clinic is it's diverse. So we use them in nail surgery post-treatment, because I offer 2 packages of nail surgery in my clinic. So patients that come in, have nail surgery, they get a follow-up appointment and go home with their treatment package, or they can have what we call the platinum package. So a Marco is included in that, so that we do the nail surgery and we see patients until they heal, the wounds of their nail surgery heal up altogether. So Marco is part of that treatment package, and he comes out every time they come in for redressings. So we know it accelerates the healing process, and on average I'd say that our recovery times are probably around about 2 to 3 weeks shorter than it would be if we haven't used him. So we use him for that, which is great because then he is part of that package. We also then use him as part of the biomechanics package. So when people come in for biomechanics or MSK, they can be coming in for any sorts of reasons that may need fascial manipulation, or it may need orthotics, or shockwave, or laser. So, and also it depends on whether it's a chronic situation or whether it's an acute situation too. So what are we actually trying to achieve in clinic? It changes literally daily. We have got patients who have seen Marco's Instagram page and Facebook page, the blogs that we've written about him, and they'll just say, I want to book in because I know it's going to help with my arthritis in my knee. So it is now interesting to see that he's no longer needing prompting from me. He prompts himself, and patients want to book in with him, and they do actually say they'd like an appointment with Marco. So yeah, lateral ankle sprains are a common thing in clinic, especially at the moment people are DIYing, and so that's really great for acute stage, but also for Achilles tendinopathy, which is obviously a chronic stage. So it literally is varied on a daily basis. And sometimes I can honestly say that he works really well in all of those conditions. I wouldn't say he works any better in one and worse in another. At the moment, it seems to be throughout the board. I haven't come across anything yet that he hasn't had to treat. We've had spinal stenosis in with referred pain, nerve pain. Now, I wasn't quite sure whether that was going to work on that, and I never promised anything to patients. So I always said, well, let's give it a go. Let's see. We know that the protocol is 3-2-1, but sometimes even after one treatment, patients are responding and they're just saying, well, that's fine. I'll say, well, come in again when it bothers you again. So we don't always follow the protocol that's recommended, as in, you know, the time span or the repeat appointments. It's just a matter of, let's just see how it goes. So have I found anything yet that we haven't used him for? No. The answer to that is no. So, I know, it is. I was just thinking that, have we actually not used him? No, he's good for anything. we're using pretty much now about 50% in clinic.
Wow.
Because we see so many things in clinic, and especially since COVID, and the NHS is not seeing stuff anymore, the physios aren't seeing. So I think they're basically coming to anybody who has an open clinic, which obviously we have done right through. And even you're in pain, you'll do anything and try anything to fix it, which is fine. So we never promise anything, and we always just say, well, let's see how it goes. And yeah, I would say 50%. It's certainly crept up in the last 6 months to about 50% of the time.
That's great to hear.
In one shape or form or another.
Yeah, with the post-op,
anything. Yeah, wound healing, like I say, acute injuries, chronic injuries. I would say most MSK patients that come in have come in for a reason, be one reason or another. So we usually see them within a week, for whatever reason that they've got. We may have given them an exercise program. They may have been on the pressure gate analysis. We may be looking at orthotics. I may have done fascia manipulation on them as well. So some people have all of that package. But with the laser, because most people are new to it, and they're maybe a little bit hesitant, or it's definitely not going to work. So by saying to somebody, look, I need you in 3 times this week, I think most people go, maybe not, or I haven't got the time. So once a week is a kind of good one to start with, because then they've had time to think about it, the process of how it works, or anything else that we may have thrown at them at the time. And I mean, I don't mean literally, treatment wise or information, because most of the time it's information that we're reiterating every time they come in. Patient education is key, and if I don't get patients on board, then I don't think the treatment plan will be successful. Talking to patients for me is one of the most important things, telling them why we do it and what outcome we're expecting, and value, I suppose I always value their opinion, and also looking at their patient expectations. And if they're working full time and they can only come in on a Saturday, well, then Saturday it is. But once a week is going to be better than no times a week. Yeah. So flexible, I would say. I mean, we're patient driven.
Yeah,
we're patient driven. So if the patients say that they can only come in once a week, then that's what we do. What I do say to them is, look, you're not going to achieve the outcome in the time span it's recommended, but actually you're going to be improving. And because we work on a vast scale of pain of 0 to 10, and we're constantly managing that, they know they're going down on the vast scale. So they're quite happy with that.
Yeah. And I suppose it depends on the patient too, because they might initially say, I haven't got time to see you to come in 3 times this week, for example.
Yeah.
But it depends what their goal is. If I'll use a silly example, if they want to run the marathon next week, then they'll find time if they think this is going to help them run that marathon next week, as a silly example. I'm sure it depends on their goals and what they want to commit, isn't it?
Absolutely.
That's why you'll encourage them to do this stretch and that stretch, and if you don't, you've got no chance of achieving your goal, kind of thing. So it's just part of that kind of thinking, isn't it?
Well, we don't do a hard sell. That's the one thing I'm very keen in clinic not to do, is a hard sell. Because I don't use it for anything else. I suppose because I've got an established practice now, over many years, moons, that people come in because they kind of know I won't have anything in clinic that doesn't work. That's it. So trust is important, and I think people do trust that I am known for having a great clinic, and that reputation goes before me now, which has taken years to achieve. So in some respects it's quite easy for me to introduce Marco, because people know that I won't have anything in unless it works. I think it's impressive to start with. I mean, he is quite big in clinic. It's not the smallest robot, is he? And people ask about him. So it prompts the conversation of what's that over there, and then you talk about it, and then they'll go home and talk it to whoever, and it gets passed on. So we do get a lot of word of mouth from conversations. So I think it's, and I suppose, I mean, at the time, and I don't know whether this is still true, but I was the only podiatrist that had a robot. So it was quite nice for patients to realise that I may have been practising for 30 odd years, but actually I'm still on it. We still have the best kit. We may live in the middle of nowhere, but my patients have the best kit and the best patient outcomes, treatment plans. And at the end of the day, just because you live in the middle of nowhere doesn't mean to say that your patients can't have the best of everything. So they know that. So they know if they've got a problem, they'll come in. And Marco does bring people in. Now, I think people, have, recognised that I have got a robot, and are clearly impressed. I mean, he's impressive. People come in because of him.
Yeah, sure.
So they come in.
There's your new business.
Because they think that they need him, or somebody else has had him, that actually it's going to be a solution for that. But it might not be. It might be fascial manipulation, or it might be orthotics, it might be an exercise regime. It might not be Marco, but he's brought them in. Suzanne is my partner in crime at work, and she's had surgery on her knee already, and she needs surgery again. And it's unfortunate, really, that it's COVID times and she's going to have to wait. But unfortunately, I mean, clearly surgery is only going to be the resolution for this particular problem. She needs a partial knee replacement. Well, partial knee replacement, not a full one. And it keeps her awake at night. She's in pain in the middle of the night because the pain meds have run out, and it wakes her up. So she goes and gets some more. So I said to her, look, come on, we'll use this. And I think she was a little bit sceptical. So anyway, obviously Marco comes out. We use both heads, but obviously use the Marco head and the handpiece at the same time, front and back of the knee. And I think she was just humouring me, really. Anyway, I get a phone call the next morning. I haven't taken my pain medication.
Wow. And
I just sort of am thinking, oh, right. So I said, so you are being truthful here now. You're not just telling me what you think I want to know. And she went, no, I haven't. So we said, well, okay, well, let's not do another treatment and let's work out how long it takes before you do. Because that's the other thing, is the 3-2-1 protocol is actually, well, how long is it going to manage just on what? Because she can be a patient and also our little study group, if you like, because saying that to patients, oh, by the way, you're a guinea pig, sometimes might not always go down well.
More treatment for 3 days, please. Yeah, sure. Yeah.
So it was 10 days before she needed. So that was the first treatment. So the first, and then even then it wasn't back to full whack. So anyway, we did it again, and then it lasted 3 weeks.
Gosh.
So, and we're talking about something that can't be changed here. It is not going to be changed. She needs a partial knee replacement. There's no gap between the bones. You can't, even Marco can't reverse that. It's so this is why we look at things and think, well, very honest, the patient's very honest to say, look, it's not going to change that. Your outcome is not, but let's get you to the surgery pain-free. And actually, when you've had the surgery, we'll be thinking to treat you afterwards. So yeah, and it was 3 weeks after that. So it's 10 days and then 3 weeks. And I think we've gone 5 weeks this time. Just had a patient in recently who's 86, and she came in because she'd seen the doctor, she'd seen the physio. She's a routine patient of mine, and thankfully, the physios are still sometimes not doing face-to-face. And he'd said to her, well, you're 86, what do you expect? And she said, well, I want to do my 18 holes on the golf course. And he said, well, you're 86, but she's done 18 holes forever. But she couldn't do it. She had a problem with her ankle. So from my point of view, it's subtalar joint problems. And it was really swollen. It was huge. And anyway, she needed orthotics because her orthotics were 20 years old and she needed updating. But I said in the meantime, well, we'll wait for those coming in. You know, we'll use the laser on you because he will bring the inflammation down and sort the pain out for you. And sure enough, only 3 treatments. And she had a 75% resolution. Because we measure our outcomes, and we've got spreadsheets going on all the time about people's outcomes. And she was delighted, and she said, okay, you know, I'm now doing my 18 holes. She said, obviously, I know I've done 18 holes because I'm 86. She said, but and she said she was going to give up. She was actually going to give up her golf. Yeah. So my argument is actually, yeah, we can't make you 26 again. But actually, can we optimize you as much as we can?
Keep your lifestyle.
Can we get as much out of you as we possibly can? Yeah. So it's an attitude, and that's what she said to me. I like your attitude. You don't judge people, and you just simply say, okay, let's go on this journey and see how much we can get out. Yeah. If we only get 20%, that's 20% more than what you had before.
Yeah,
75% after 3 treatments, and of course, then she's told all the ladies at the golf club. I would recommend MLS to other podiatrists, and actually have done already. Obviously, podiatry is a smallish world, so we tend to get messages behind the scenes, and I have no problem with talking to people about it at all. As far as I'm concerned, it raises podiatry and podiatrist's game, if you like, because at the end of the day, other professions' perception of us, we just cut toenails and we just do routine care. And it's like, actually, no, we don't. We do an awful lot more than that. And so from my point of view, I just think if you want to improve your podiatry game, you need to do it in a way that is going to actually make people listen to you and see that you can do more than just routine podiatry. So Marco does that for me. So I'm more than happy and do speak to quite a lot of podiatrists about it. Because actually it's the truth. I mean, at the end of the day, I'm not getting paid for any of this, as you know. So I don't have any, you know, it's no conflict of interest for me. I just think at the end of the day, it really works for me. So if you want to improve, you know, this is this is one of the ways of doing it. And why not? So yes, I do. You don't sell it. You don't have to. You just have to tell everybody what he does.
Yeah. That
sells it in itself. Yeah. Because people want to go, well, how much do you charge per treatment? Or how, you know what I mean? It's categorized in units. And I think, you know, he's part of a bigger picture. He's part of multiple treatment regimes that we do.
Yeah.
And the high-end ones. You know, so if you're doing nail surgery and you're having Marco afterwards, it's not Marco's charge, it's incorporated in the high-end nail surgery treatment package.
Yes.
The MSK ones, you know, it's like, this is what we need. And so, yes, he is charged on an individual basis, but most of the time he's brought into other treatment packages.
Sure.
Which are more expensive.
Yeah. Yeah.
And that's where most podiatrists get stuck in their heads of, gosh, this is an expensive piece of kit. How am I going to make my money back? Actually, it's a little bit broader than that. By getting your money back, by you getting the right kind of patients that you want in. We want the patients who we can fix, that need fixing, clearly, and that are also going to be happy with the outcome, and they don't mind paying. They just want to be fixed. If you're looking at what comes in your clinic, and if it's in a chronic stage, it's very different to an acute stage. So you don't use Shockwave in an acute stage. So therefore, laser is your weapon of choice, if you like. So I always use laser in acute conditions. There is absolutely no reason to use anything else.
Okay.
From a chronic condition that's been around for longer than 3 months ish, I use the two.
Interesting.
So Achilles tendinopathy, that obviously the Shockwave will stimulate it irritates, doesn't it, to stimulate the blood flow to the area, which is a particularly difficult area to get through. Achilles are known for being not particularly vascular. But then I'll pop so as I'm moving, well, in fact, actually, I've got a lady at the moment that's got a double Achilles tendinopathy, and she's got it obviously bilateral, and had it for 4 years. So it's challenging in its own right. So we've used the Shockwave for 4 times, along with the laser at the same time, because I can. It's so easy to use Marco's head when I'm off doing something else or using the handpiece. Yeah. So consequently, yeah, we will use the two together. And why not? From a patient point of view, they're getting the best of both. So it works. I mean, obviously we'll be using the exercises and fascial manipulation as well. Although strange that she has no fascial problems, but she's an active lady and wants to keep active. So she's quite happy taking it slowly. So yeah, we use both in totally different contexts together and apart, depending on whether it's acute or chronic. So if somebody comes in with plantar fasciitis, say, that's a good multifactorial problem that everybody probably dreads. My point of view is patients come in and they've maybe had it for God knows how long. They're in a lot of pain because it is really painful. So I will laser immediately. So even if it's been a chronic stage and it's been there 18 months, I will laser first and I'll strap and disable the foot, if you like, because the whole point of strapping is to create another fascia to take the load and just to give those muscles and the fascia a break, in very simplistic terms. And I may do that 2 or 3 times until I can bring that pain level down. Okay. So strapping and fascia, I may do, like I say, fascia manipulation, or I may do laser, I may do strapping, or I may do all 3. It depends on what's causing the problem, because it's multifactorial. It's never just one thing. Footwear change. And while we're going down that journey of once a week doing that, we'll get to a point where I'll go, right, I need to Shockwave this a couple of times now.
Okay. Just
to get things moving a bit.
Yeah.
And laser at the same time, because they like the laser, because they know it works.
Yeah.
But I'm looking at accelerating it a little bit quicker. Because I'll say to them all the time, my job to get you fixed and not for you to sit in this chair again. So that means education, it means footwear education, exercise education. It's a whole process for plantar fasciitis. So trying to make it as simple as possible is that if you've got a patient then it's absolute agony, I wouldn't jump to Shockwave.
Okay.
Because I would never see them again.
Right.
They'll be like, I don't think so.
No.
But if I can lead them down the garden path to maybe treatment 3, when it's got down to the level,
okay.
And that's level and that's laser and strapping, or maybe fascial manipulation as well, depending on what's going on. But then I'll think about Shockwaving.
Okay.
But I would never go to Shockwave straight away, because they're not. If you've had this agonizing pain for 18 months and somebody says, oh, by the way, I'm just going to put this on it. And they'll be like, no, they're just not going to wear it. I know they're not. And it's also their headspace. When people are in pain for long periods of time, the thought of having a little bit more pain, not a chance.
Right. Sure.
They're just not.
Yeah.
And it's the struggle sometimes, because it's like, well, okay, now you trust me. Will you trust me a little bit more and say, look, this is the next stage now. This is what we have to do. I mean, that's what works for me. I'm not suggesting that's a protocol that is standard for most people, but because obviously we've been doing it for a long time now, it's like patient expectations, but also patients are quite fragile when they're in pain.
Yeah.
Mentally, they're very fragile.
Yeah.
And if anybody has been in pain, you kind of know that that is the case.
Yeah.
And the first few treatments, they're just not sure. They're just not sure about you and the treatment. But once you sort of gained their trust, if you like, and said, look, you know, this is what we do and why we do it, and this is the journey we're going to be on, but actually, you know what, long term you're going to be out of this problem, but short term it's going to take, you know, at least, I don't know, 6 to 8 weeks or whatever, of saying, look, this is where we need to be. So it's getting their trust. Well, MLS laser, or certainly the M6, because I can't speak for the others, but it's impressive, it's invaluable, and actually it's a game changer for clinic. If you're wanting something to impress patients, you have a robot at the door as they're coming in.